We come to you from the land of EM to share the impact point-of-care ultrasound has had on our practice of emergency medicine. We're going to share 3 cases of chest pain. In each case, a bedside ultrasound significantly altered the patient's plan of care, resulting in early life-saving interventions. Let's take you to our first case.
This is an 81-year-old female with a history of COPD and atrial fibrillation, presenting with 2 days of chest pain and shortness of breath. She was tachypnic and tachycardic with no ischemic EKG changes. Initial management plan included cardiac lab work and CT chest to evaluate for PE. Point-of-care ultrasound was obtained, showing right ventricular enlargement with D sign and McConnell sign, suggestive of submassive PE. Heparin infusion was therefore started and CT scan was expedited, confirming the diagnosis of PE. She did become transiently hypotensive and was admitted for urgent thrombectomy.
Our second case is a 44-year-old male with a history of hypertension presenting with 5 days of chest pain, back pain, and shortness of breath. He was hemodynamically stable and workup showed elevated troponin and EKG with T-wave inversions in inferior leads. There was initial concern for ACS versus PE with a plan for empiric initiation of heparin as the patient was refusing CT angiogram. However, bedside ultrasound was obtained showing a dilated aortic root with aortic insufficiency and possible dissection flap. With these findings, we were able to convince the patient to undergo CTA, which confirmed the diagnosis of type A aortic dissection. He was emergently taken to the operating room and ultimately had a good outcome.
This is a 57-year-old male with past medical history of coronary artery disease, hypertension, status post-ablation for atrial fibrillation 10 days ago, who presents with chest pain and shortness of breath. He was found to be hypoxic and hypotensive with a normal heart rate. EKG showed no ischemic changes. Initial plan was for resuscitation, lab work, and CTPE. POCUS was performed and showed a large pericardial effusion with right atrial and ventricular collapse, consistent with cardiac tamponade. The patient was emergently brought to the operating room for pericardial drain placement with removal of a total of 1 liter of blood.
Each of these cases presented had specific factors that prompted us to perform a bedside ultrasound. It can be particularly high yield in patients presenting with additional concerning features, such as shortness of breath, abnormal vital signs, back pain, or recent procedures. Although bedside ultrasound is not performed on every patient presenting with chest pain, these cases we have encountered demonstrate the utility of ultrasound to aid in the early detection of acute life-threatening causes and expedite emergent interventions. We hope our cases motivate you to consider the benefit of early bedside ultrasound in your next patient presenting with chest pain.